One university, and it was streamed through YouTube, and they inserted the various pictures simultaneously, and it turned out without a hitch.
Okay, so it's just telling me now that it's
at Des Moines University.
okay.
And it was streamed through YouTube, and they inserted the various pictures simultaneously, and turned out without a hitch.
Got it. Okay, so it's just telling me now that
Yeah,
it's
saying live on YouTube.
One university.
okay.
And it was streamed through.
Do you have the YouTube account? I'm actually trying to look it up.
Actually, yeah, it's live streaming now. That says 3 people are watching. Let me. But you know the problem is that there's a delay.
And it's also blocked at the hospital. Just so you know, that YouTube channel is blocked at the hospital.
Are you getting the feedback, the double feedback? But you know the problem is that there's a delay.
And it's also blocked at the hospital. Just so
Yeah,
you know,
it's really delayed.
that YouTube channel is blocked.
Okay, now.
Why not just do like a PowerPoint presentation and just
Are you getting
broadcast it over these
the double
channels?
feedback? Hold on, let me see if I turn it off. Is it still going live?
And it's also blocked at the hospital. Just so
Wait.
you
Yeah,
know,
it's really delayed.
that
Okay, hold on a
YouTube channel is
second.
blocked.
Let me just turn this.
Why not just
off.
do like a
Are you guys there?
Yeah.
Okay, no, it says live on YouTube right now. Can somebody check YouTube?
I just
Let
don't
me,
know where to go on YouTube for it.
What's the
I'm
website?
gonna put YouTube right now on our YouTube channel.
Okay, if you look at the upper left-hand corner of your Zoom screen, there's a link. Okay,
Yep,
go
I-
way up there, and there's a little link, and you click on live YouTube, and you can view it on YouTube if you can view it.
Yeah, the problem is if you do that, you're gonna get double feedback. And I noticed that the YouTube.
Yeah,
is
just
a
turn
little
off your
delayed.
microphone. Yeah, just turn off your microphone if you're doing that.
And at the same time, there's a link where you could copy the stream. So you could, there are 2 options there. There's view stream on YouTube and copy
There's a little link.
streaming link.
Well, I guess we could maybe once we started send that link to everybody.
Yeah, we just have to send the link and then tell them that they can get off of the. They can get off of the.
The Zoom. Mhm.
For some reason, for some reason now the image is not going.
What you can do is you can tape the ceremony in Zoom and then
good.
upload it to YouTube after the fact, so that everybody has
Yeah,
access to
no,
it.
but right now we're live on YouTube, so we're transmitting live on YouTube. So this is actually going to be a good check for it. So okay, so I think we fixed the problem. How about that? What a productive meeting. All right. So Liz, anything else on graduation?
No, that's about it.
Okay, program directors, anything else on graduation?
No, I'm okay. I'm happy with that.
So we're gonna do it all the same day. We're gonna tell the residents that they can only have one invitation, which is for themselves, and that everybody
For Zoom,
else can go and watch on live YouTube. Right.
Yeah, so we'll do.
So
We
they
can
can do
send.
the
We'll
family
send the
that
link to them. Exactly, and they'll forward it,
Yeah.
and then
I
one
missed the
picture.
first
Right,
one.
one
Reality,
picture of each.
the residents are not going to, the residents' family members are not going to be intervening. They're just gonna be watching. So they just watching it live is enough.
No, but I'm saying we'll give the link to the grads that day so that they could forward it to their family members, and then the family members will get on that link.
Yeah,
The
for the
YouTube.
YouTube. It's the same
the
link.
YouTube,
I don't know. You know what? It might not be the same link as this one. It might be a different link.
I missed the first couple of minutes. Do they need to prepare anything in advance or no?
No, what we're doing is that we're getting a picture. Each of the coordinators are going to work with the program directors. Are going to get a picture of each one of them. Then each program director, hopefully you have right now, like you don't have a picture, but hopefully you have.
Yeah,
a
I can
picture
get one. Yeah.
No, a picture of you, like of you talking actually.
Yeah, video, yeah.
Yeah, just turn on your camera on the Zoom, and then we will be putting in the names of each of the people as you introduce them. So you'll be able to read off the names off of your screen.
Gotcha. Cool.
And then you'll have 2 minutes to talk a little bit about your program, and then we'll go to the next program.
It's a kind of PowerPoint, no?
Yeah, we'll just run it through. Liz is going to go through it, and so each program director, like right now, you're talking. As you're talking, your image is going to be on the side, and then we're going to share the screen with a picture of each of the residents, of your residents.
So Dr. Michelle, do you want me to then turn off the sharing when the PD comes on and talks? And then turn on the sharing when they
because
stop talking?
you can see the if you want to see it right
Two
now.
on the bottom.
Yeah, if I share my
Yeah, you can see it
screen
on the
right now, you will see that you can
Yes,
see my
I see.
screen.
I got it.
Yeah,
Yep.
yes, yes.
Yeah,
I can
so
see.
Whoever's speaking right now, you're gonna see it in the corner. You see what
Okay,
I'm saying?
perfect. Yeah.
So you don't need to do that. You could just make
Perfect.
it. Yeah.
Yeah,
All right.
perfect.
So anybody have any questions?
Can I make a suggestion to have like the graduation music playing in the background?
I like that.
You know,
Yeah.
da, na, 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 na. No, just kind of quietly in the background where
right.
everyone's talking. It'd be kind of cool.
Now I don't know how we're gonna do that.
And let's loop it. No, she just has whoever's hosting the meeting has to play that.
You know, there's a video setting. There may be a way to put music on the background here. I mean, you could choose a virtual background. Like I can have this background or any background.
Wait, did you
So
get
actually,
that?
I could do this, but I don't know about music. You know, we need to explore that, Liz. I don't know about music.
Okay, I'll find out.
Yeah, maybe something really low.
Yeah, live music, no reggaeton.
Yeah, no reggaeton. Does anybody else have any other program directors, chief residents, or residents have any questions about graduation?
Yes, I have a question. I apologize.
Right,
This is Ferris. So are we doing the thing where we make a video of ourselves and send it to Duberling or no?
No, because I think it's just going to be very complicated to put those together. I'd rather have a picture of you
A picture, yeah.
with your name underneath, and that's it. And then as the program directors will present each one of you, and then that's how we're going to do it. And then the program director will have a few minutes to. By the way, if anybody wants to, I mean, we'll count the time to make sure that we have plenty of time. But if any of the program residents or program directors want to do a little bit more than 2 or 3 minutes for whatever reason, then you can talk to Liz. I just want to make sure that we don't go beyond. What did you normally do? Like about 1.5 to 2 hours?
Yeah,
Liz?
last year was pretty much an hour and a half, an hour and 45 minutes.
So as long as we can keep it to within like 2 hours and we're not gonna get people bored, we could possibly have a video of all the residents together. If you guys want to put that together, that's great.
Like a compilation? Okay.
Like at the end of the everything, we could put a video of like each of the programs could have the little video of them working or whatever they want to do or activities. We could do that towards the end.
And then, so we're separating the graduations though, right? By campus?
No, I don't think we need to. If we're going to do this, we'll do live. Yeah.
Okay.
So we'll do like the little PowerPoint of all these videos of them at the beginning and then at the end, because you know how it is at the beginning. Like it'll take like 20 minutes for people to actually sign in or whatever. So during that time, at least they're watching something, and then maybe with something saying, graduation coming soon or something, and then that way at least they can see something happening.
Okay.
Rather than us talking. Okay. Any other questions about graduation? All right. Second question is, we have a lot of people here, so we have a kind of a big agenda, and I don't want to do it more than 2 o'clock. So I'm going to try to kind of compact it. The second thing is the orientation process. Liz, you want to orient the program directors and chiefs as to how we're going to do the orientation and anything they need to know?
Mm-hmm. Yes, orientation is going to start June 15th. We're going to go ahead and do it virtual through Zoom. I actually wanted to ask, I had been emailing yesterday the IM/FM chiefs, and you guys had emailed me back that you definitely want to present the IM units, the FM units, the ICU units separate, right?
Yes.
Okay. So we'll go ahead and work in doing that for you guys. And then the ER, since everybody's going to Palm Springs, even the South Miami residents, then you'll just do one presentation on the ER.
Yeah, that sounds good. That makes sense.
Okay. And who wants to present the ER? I'm not sure if you guys answered on that. FM or IM or both?
We'll have to
Maybe
get back to
either probably Alina or Frank. I mean, as PSC, and we probably know the ER a little bit better. So and both of them will be there. So either one of them.
Okay. And then ICU South, who wants to do that one?
We can do IC South. I am can do it.
I'm sorry, what?
I
I
am.
am can do IC
am.
South. I am can do IC South. We can do it.
And then ICU Palm Springs?
Frank.
That'll be us.
Who's us? I'm sorry.
Frank.
Okay, so I am Frank, and which is I am Palm Springs. And then for ICU South is I am Palm Springs as well, Chiefs? Or are you guys joining?
I am South. I am South. The Chiefs from I am South.
Perfect. Okay. Okay. Let me get back to the schedule with because Kiana Marie are doing the schedule, so they'll go ahead and schedule it. But just so you know, it's going to be on June 15th. The first day it's going to be HR, and it's going to be separated in separate campuses. So the HR in each campus will present to the incoming through Zoom. And then on Tuesday, we're actually going to join both campuses, and that's when I'm going to do the GME presentation. One of the lawyers is going to come in, and she's going to discuss malpractice and that information, which is very useful. And then the inpatient units, some of you guys will present. We're going to go ahead and separate it then. So you'll present to one campus, the inpatient units, and the other residents the other chiefs will present to the other campus. Because we're trying to join as many presentations as possible for those people in departments that kind of share a lot of information or share the same processes. That way it's less time that everybody's presenting overall. But basically the first week, it's pretty much all gonna be Zoom presentations with different departments. On Friday of that week, most likely that's when we start the systems training, the HMS and the electronic medical records training. Program directors, if you want some of your incoming to go to your clinics, especially the new clinics or the new programs that just started, let us know, because the last week of June 22nd, that's that first day of that Monday, that's when we're going to start scheduling any clinic orientations that you might want to do with your incoming. Some programs, the chiefs do that. Some other programs, the incoming actually go to the clinic. So just work with your coordinator to let them know, FYI them of how it is that you want to handle it. In case the chiefs here are listening as well, work with your PD, the new chiefs, of how you want to handle those incoming with the not only clinic orientations, but maybe their office orientations, like anywhere that they would need to spend a little bit of time. That way we could schedule it that last week. The incoming are going to have the ACLS BLS done. They're going to be doing it through CPR Depot Miami. I know that we have a few days scheduled for the current class. So chiefs or anybody else on this call, if you have your ACLS BLS expiring, you could go ahead and come at the end of June to get it renewed. And then the incoming will do it the last weekend of June. So they'll be ready to start. Let me see.
This is Norm Rose again. In the past, I had most of the internal medicine residents and surgical residents rotate over at Nova in the simulation lab for CVPs, chest tubes.
Yes, that was
I don't know if you coordinated that yet.
Chief,
I don't know if you're going to arrange that.
I wanted to ask, let me find the list that I had, but is that procedures course, that's something that's definitely required for the incoming, that you would suggest that to be done?
Yeah, it gets them familiarized with, again, the procedures, and it makes it a little bit easier once they get to the hospital. Some of them, we go ahead and review the gloving and gowning, depending upon what area they're in and things along that line. So it's a pretty good simulation lab. We have all the CVP units along with the ultrasound for CVP placement. So that's worked out very well in the past.
Okay, and the people we have usually sent there are the IM, FN, neuro, and psychiatry interns for the advanced procedures course, and then we usually send the general surgery for the general procedures course, the basic procedures course. You would agree with that, Dr. Rose?
Well, I want to make sure that the incoming surgery residents get, I'm not so worried about their gloving and scrubbing and all that, more or less is some of the procedural things that they're involved with as far as taps and chest tubes and things along that line.
Because they usually do the basic one. Do you think that the incoming in the previous years have done well with that basic course? I don't have a list of the procedures in front of me, but
I'd have to take another look at it. I'm not sure. Since I've been in all of them, I'm just not sure which ones
okay
would be best for them. Yeah. So I'd have to look at the list if you would send it to me.
Okay, and then for the IMFM neuro and psych programs, chiefs, do you feel that I'm not sure if you guys actually attended that course because we started this maybe 2 or 3 years ago, but do you feel that procedure course for orientation is necessary for the incoming?
I attended it last year, and I think that it was very useful. So yeah, I highly recommend it for the incoming interns.
Okay, because we usually gave it to, okay, it's IMFM neuro and psych, because you guys, I think usually do surgery where you take a month or so. I don't know if any other program would need that, or.
Yeah,
I agree because it wasn't just for surgery, the central lines, IV placement, things like that, I think were very relevant for all the residents who will be in the ICU, things like that.
Okay.
I think that every surgical residency program should attend to this video. It's very useful.
Okay. What I'll do is I'll send the surgery program, the different procedures of the basic versus the advanced. We usually send them to the basic one because essentially you guys will learn the other procedures, I guess, as you know, in your residency. And then we would send advanced to those that didn't really get as much experience so they could learn a little bit more. But I'll send you the procedure list for both courses. And then, I mean, in case we want to upgrade the surgery to the advanced because it makes more sense, then we could go ahead and do that as well.
This on the agenda, we had, I remember that those suggestions that the SCGME had as far as new things to add to the orientation, such as COVID awareness and that type of stuff. Mm-hmm. Are we incorporating some of that?
Yeah, that's basically, I think, would be more of the hospital as well. Like protocols or procedures that might have changed within the departments. As far as the GME is concerned, other than them quarantining to come in, as far as like my presentation, I don't know what I would really add when it comes to that.
So just for everyone to understand, so everybody's going to get quarantined for 2 weeks before they can actually start at the hospital. So they need to be here on the 15th of June, right?
Yes. Yeah.
Okay.
Yeah,
so we're doing that
sure
across the board with asymptomatic. We want to quarantine them before they come in.
Mm-hmm.
We are not going to do any test to the incoming residents.
No, we're not going to test everybody, but we are going to quarantine them. And if they have symptoms, we're going to test them.
Okay.
Yeah. It's too much of an issue to test everybody. So I think we'd rather just because right now not every resident has been tested either. We're only testing people that are that have some type of symptom. Okay. So obviously, if they do have any symptom of any upper respiratory illness, a headache, things like that, they should get tested. Liz, anything else?
Mm-hmm. Let me see. No. Oh, and schedules, guys. Chiefs, if you haven't submitted your schedules yet, please make sure to send it to your coordinators. Those coordinators that haven't received it, they're going to be following up with you to make sure we receive it ASAP. We need to start putting those into the system already.
Okay, Liz, do you have anything else for GME?
No, that's pretty much it.
Okay, any of the chiefs have any? I'm going to start turning it over to some of the teams that are working on some of the COVID work, but I want to, before I do that, any of the chiefs have any comments or questions? Or any program directors? So let me turn it over. Is anybody here from Team 1, the peer support group for COVID? So we have a team. Actually, Virginia, you want to tell them a little bit about the team? If we don't have anybody here.
Is there anybody here from peer support?
Yeah, I guess not, but.
Okay. Hi, everybody. I'm Virginia Johnson. I'm one of the volunteers that got involved a month or so ago with Larkin. And the peer support team, which is about 7 people right now, have been reaching out to patients who were previously tested positive and offering peer support. And it's a lot of mental health workers and people who've got experience in helping people just emotionally through this. As we go through the contact tracing, as we start that, we're going to be offering more peer support to those patients so that I think that the volunteer team for peer support is going to grow as the need grows. But right now, the peer support team has done a really good job of reaching out to a lot of prior patients and giving them the support they need.
Thank you, Virginia. Team 2, plasma group.
Hi, yes. So for team 2, we've probably reached out, we're collecting plasma for both hospitals, and we've reached out to probably around 300 patients that have said that they want to donate. And of the 300, we've already sent over about 112 to the blood bank. And we have about 40 units right now of plasma between both hospitals.
And how many people have been transfused between both hospitals, have received plasma transfusions?
That I don't know because I'm not working directly in the hospital.
Millie would have to answer that question in Onel for Palm Springs, but I think the number is over 20 at Larkin South.
I can ask them.
And then
do we know how they're doing on the plasma? Are they doing well?
Actually, very well. It was so encouraging. We got a lot of people off ventilators and things like that. But actually, Patrick got FDA approval for early plasma administration from the FDA. Patrick, you want to talk a little bit about that?
Yeah, it's impossible to know if the plasma works unless we do a randomized controlled trial. So that's what we started doing, randomizing them 1-to-1. So hopefully we can answer that question.
So apparently, even though they've been using it for over 100 years, there's never been really a randomized trial that's proven that plasma works. Because I guess they were trying to do it for Ebola, but by the time they started it, it had already been, it was resolving. So they couldn't really get the data other than some anecdotal stuff. So hopefully this will be able to actually prove it. And Patrick has been working on that. Then we have team 3, which is basically designing an app. Anybody, is Camilo here? Maybe not. I don't know. Maybe John, you can tell them a little bit about the app because you probably know more than anybody else knows, right?
Me? You want me to talk about the app?
Well, you know more about it than I do.
Well, no, it's actually coming along really well, and Camilo's done a great job. We're finalizing some of the details, but in short, it is user friendly for. Sorry, now I have a dog in the background. It's user friendly for people to track their symptoms as well. It is very helpful. It's a great contact tracing document. So, and it'll work in real time with both the CTFs, our contact tracers, and we're calling them PUIs, the people under investigation. So as they're talking with, as the CTS is talking with the PUI, either one can be putting in contact information. And the app, which soon will be on Apple, in the Apple application store, as well as Google Play, they can be, you don't even have to talk to a person. It can all be done by the person under investigation, the COVID positive person. They can go on, they can fill all the information out. They never have to talk to a contact tracer. But the idea is that for those who need help, the contact tracer will be helping them fill out the information, and then we can contact the contacts of that person.
Perfect. The next team is team 4, which is the clinical guidance team. I don't know, Humberto, if you're here, or Farial, or...
Yes, I'm here.
Okay, go ahead, Humberto. You may give a little update on what team 4 has been doing.
Yes, for everyone we diagnosed with COVID, we start with the protocol that we have been handling. So Sofluza, azithromycin. The patient get admitted and have a decrease in saturations. So we start with the steroids and 1 milligram per kilogram for 5 days. Once the patient require additional support, like no invasive pressure, nasal cannula or BiPAP. So in that case, the patient is moved to the ICU. And that is when we are starting different protocols. Recently, we have been working before with tocilizumab with patients. We have cytokine storm evidence with the markers. But now there is a trial that is about to start we're gonna start a little earlier. The other thing, all the patients have receiving early plasma with excellent results. There is another group that is receiving remdesivir that we haven't seen much improvement. The other thing that we have seen with the remdesivir is that we increase a lot of fluids, and in the COVID patient, we want to keep it dry. But every time we administer the remdesivir, the first time is 200 milligrams with 100 cc's. It's going to be for 5 days. The second to the fifth day, it's going to be 100 milligrams per also. So we increase like a half a liter. And those patients that we want to keep dry. In addition, some of them have antibiotics. So that's the idea that we don't like so much, especially is the patient have some kidney issues. Yes, the other thing that we are including is a trial. Apparently affect the glutathione oxidase and reduce the free radical is with the mucomis. We're starting with three different arms of the trial. One is going to be mucomis only in nasal. The other one is going to be with nasal IV, and the other one with the IV only, and a control group as well. So they are developing that trial already. So far in Larkin South, we have an excellent statistics, and we are trying to publish that statistic with the protocol that we are having. So mortality has been so far 0 in our hospital. And yeah, Dr. Michelle is conducting the publication with us. I don't know what else now.
Thank you. Any other feedback from Team 4? Let's go to Team 6, which is the National Staffing Registry. And this is something that was started by Alejandro. Alejandro, are you on the line?
I'm here. Hello, everyone.
Talk a little bit about what you're doing. Alejandro is in Mexico, and he's been helping us develop this program.
Hello, everybody. First of all, sorry for my Spanish-Dutch accent. I hope you can understand me. I will try to speak slowly. And what we are doing is developing a landing page where the staff, where the medical staff can register to find a job, and also where the employers can put the offers they have to, well, if they are hiring people, if they needing people, they can put in our landing page their jobs offers. And well, if a nurse or someone else need a job, they can go there and try to find something that fits their needs. And this will be ready the next week. We are working hard to have it ready as soon as possible. I'm trying to launch the page on next Monday, the 25th, and perhaps on Friday will be open for the public. In the meantime, our team is working to find people who needs the jobs, to find employers, to get the page ready with all these offers when it begins to work.
Thank you, Alejandro. And so the purpose of this is really, it's a national database. So it's not just for South Florida. The idea is that people all over the country can put in their resumes, and then we try to match them with local hospitals, and it's totally free for both sides. So Alejandro has been working as a volunteer on this for a long time, multiple hours. Good job, Alejandro.
Thanks, doctor.
And I don't know if Laura is here to talk about what she's doing with the calls. Maybe she's not. Laura, you here? She's another one of our volunteers working with, we have 3 lines, English, Spanish, and Creole. And so we have a whole group that answers calls either for plasma donation or to sign up for a volunteer group. Susie here for team 9, the discharged recovered COVID-19.
Yes, I am. Hi, Dr. Michelle. How are you?
Good, and you?
Good, good. So yeah, I can give a quick little update on how we're doing. So we recently just got started because we were having difficulties getting the names and getting the HIPAA compliance forms for our team. Basically, what we do is we call up patients who are discharged with the virus, and we call them up a few days after their discharge, and we just ask them how they're doing, if they need any resources, if they have any symptoms, especially if they have a pulse oximeter, we ask them how their oxygen saturation has been, if they have any shortness of breath, things like that. Any difficulties getting food, getting groceries, and then we refer them to the specific people that can help them with that. I don't know if I have any team members here who want to talk about their experience calling a patient. I see Pamela.
Pamela
Hi,
is an
Susie.
incoming anesthesia resident.
Yes. Hi, Dr. Mitchell. Hi, Susie. Hi, everyone. So yeah, I'm gonna start on July 1st. Very excited to be part of the Larkin family. I'm also a part of Team 9, and I had 2 patients to call. One of them, we happened to have the wrong number. Well, they wrote the wrong number on the consent. The actual patient wrote a wrong number for one. And then for the other one, I spoke to the patient's proxy, was her granddaughter. And it was interesting because I asked her if she has had, how she's doing, any symptoms. But she said she's in a nursing facility, in a nursing home. And she's been taken care of, that she has been completely asymptomatic throughout her course. She was actually hospitalized for something else and incidentally found to have COVID. So she said she's asymptomatic. I asked her if she wanted to get in touch with team 2 for the plasma donation. So she said it all depends on the day, how she's feeling, because a lot of her comorbidities affect her mood. So it's basically however the patient is feeling at the day they call her. So, you know, what we do is we refer them to different teams according to what their needs are. She didn't have any specific concerns or needs, so that was about it. She's doing better.
Thank you.
I did have a question, quick question, Dr. Michelle. A lot of our callers have been saying that they don't know who to refer the patients to if they want, for example, peer support, or they want to donate plasma. How can we put them in contact with
you
them?
know what? Send me an email, because Virginia and I have been working on something for like that for Team 1. I'll tell you. Let me confer with her, because we're finalizing that. But for Team 2, the only thing is, what is it, Andrea? larkincovid19@gmail.com, right?
Correct.
So just tell them to email larkincovid19@gmail.com, and then Andrea gets those, or Marsha, I think Marsha gets those, and then she screens them, and then they go to plasma donation. So that one's easy, the plasma donation.
Okay, perfect.
They can also call. There's also a phone number if they want to call a phone number. We have 3 phone numbers. If they prefer Spanish, it's 786-876-6806. And if for English, is 786-876-6606. But I can give you this via email also.
Perfect.
So they can do via phone, or they can do via email. Susie, tell them about who you are.
So I'm a current dietetic intern at Larkin. So I'm on the road to becoming a registered dietitian. I completed my clinical rotation at Larkin, South Miami. So I was there for about 10 weeks. And now I am completing my other rotations outside of Larkin.
So we've had dietetic interns, we've had the dental residents also helping with the plasma transfusion. So we've had pretty much every resident intern working on and helping, plus 800 volunteers who were really helped out a lot. And talking about that, Team 10, Obi, you want to give a little summary about what Team 10 is about?
Yes, thank you so much, Dr. Mitchell. Hi, everyone. My name is Obi, and I actually have one of my colleagues, Dr. Sean, on the line. So we'll be making this presentation together. So right now, as Dr. Mitchell rightly said, we have almost 700 volunteers, and we are still at the planning phase, and we're trying to make sure everybody's trained for the next phase, the operational phase. So I'm just going to quickly project my screen. Dr. Mitchell, if you allow me to share, so that I'll just share a little bit of idea of what we're doing. Okay.
You got it?
Let me try now. Oh yeah, I think it's working. Thank you. Yeah, so thank you everyone for your patience. So we're trying to make sure everybody is trained, and Dr. Mitchell was able to help us get access to the Association of State and Territorial Health Officials free certification for contact tracers. So we call that our Credential of Readiness Training, our core. So that's what we're doing right now. We've been able to have over 200 volunteers, complete that. So, and we're actually moving to the next phase, which is a skill development laboratory, is where we give them opportunity to, practice how to make these calls and interact with one another. So we're hoping to start that next week. Give me 1 second, let me move this forward. Yeah. So these are the tasks we're trying to accomplish. 100% completion rate for the core training. And we want all our volunteers to get comfortable, using our COVID Fighter app and all our technology platform. We're equally designing the curriculum right now for the basic program. And these are timelines we're looking at. We're looking at getting 100% completion rate for our core training by May 30th, 2020. And we're hoping to do the basic training between May 30 and June 1. And when we go over to the implementation phase, how it's going to work out is that Virginia is going to share the list of contact people we're going to be reaching out to with our regional heads. So we have about 10 regional heads across the United States. And each of the contact tracers are going to be reaching out to this contact using a pre-made script. And that script is already developed by Dr. John Capel. Dr. John Capel, you've heard from him earlier. He's an educator with over 30 years experience in training volunteers. Worked extensively in Guatemala and the United States. So he will be taking care of that. So that's basically the summary of what we're going to be doing within the next 1 or 2 weeks. So I'm going to turn it quickly over to my colleague, Dr. Sean, to talk about, the partnership we have, relationship with CDC and the communication arm of what we're doing. Dr. Sean, are you there?
I am, sir.
Yeah, please take it from here.
All right. Good afternoon. I'm Sean Ragone. Some people sometimes pronounce it Ragone. It's okay with me either way. What we have done is developed a communications department, myself, Don, and Hamani. And what we have contacted the CDC, I have a connection just from my 20 years with them that is going to help us in any questions we have regarding disseminating information, CDC's involvement in any of these programs or needing to be updated on anything. Essentially speaking to the CDC EOC, the Emergency Operations Center, I received an email back from my request that I put in as a form of question, and they stated that the federal government is just giving out guidelines and they're not taking in any data by individual groups. So what they are relying on, from my understanding, is that they will be the state departments of public health will be the metadata that they have will be shared with the federal government and their own national public health network for states. So we've got that connection set up. We have a setup connection also with we're going towards media outlets like we're starting local with the Miami Herald. We have a connection there set up and discussions. Hopefully what we're going to try to do is plan our communications department's release around the time that we start releasing the program or setting it in motion. We have to remember that unfortunately in public health on a state and federal level, one hand sometimes does not talk to the other. And usually in my experience, this is because of funding. So when money's involved, we in our program will have a disconnect on communications, or we'll get confusing information on who does what. And it's a lot of go talk to them. We go to talk to them. They say, go talk back to the other people. So this is why I think our program is going to be largely successful, because we have historical facts on our side about second waves and epidemiologic data that we already know from the pandemic of 1918. And with that, we're going to use that as a blunt object to try to get them to understand that you could say that you don't have contact tracers or it's in the works. We already have 700 plus contact tracers. We already have the infrastructure in place. We're completely free. Everybody's responding to their call of duty, and even other nations. And I'm going to hope that this approach, along with some guidance and help from other friends of mine who are medical communication experts, in order to have a more robust opening, and also have some a media event that has a podium, hopefully, or something to that effect, that will draw attention and have other cities be able to say, you know what, we want to use Larkin because they're ready to go. So that's basically our communications and press approach for right now. And I'm still waiting back for the state of Florida's contact point for this area of the state to find out where we're going to send the information to them. But that's where we are right now. Everything looks good, and we're ready for the opening shortly. Thank you.
You want to explain a little bit, Sean, about the teams, like how about the different regions and how
So,
we have it organized?
Okay, so basically this map, I'm sure a lot of you are familiar that the United States is broken into divisions or into groups. And these groups, this organization model is how the federal government also deals with funding, stockpiling, and answering questions from each head. So this local municipalities can contact their State Department of Public Health, and then have those people contact the federal government. So we have an internal communications portion to our program as well. We will be communicating with all 10 regions regarding anything that has to do with social media and press or statements, and also any questions that those public health departments have for should they contact one of our contact tracers, which could plausibly occur. So we're going to be having an internal communications department and an external, and this is following along a route that has already been paved, decades and decades ago. So now that the group is up in the Telegram, anyone from the 10 regions can be calling us. We have to remember that right now everything is on. It seems a lot of these data is on the down of the curve, but this, again, history repeats itself. This will have a secondary curve or upswing, and we have to be prepared for that. If we are not prepared for this on any level, then we're going to have more communication issues as far as trying to communicate with the health departments and with each other. So hopefully this helps keeps a continuity of flowing information and what else is on the coming through these different departments. The other thing is we've developed a Snoops like department or part of the app so that we can do rumor control. Obviously, there's a tremendous amount of rumors. Everyone in here, regardless of your background, I'm sure you've heard some cockamamie hypotheses and conspiracies. We're going to help it's going to make our app unique because we'll be able to dispel those based on the CDC's information and cross-referencing it with things like Snoops and other reputable outlets. So basically the infrastructure is there for all 10 regions. And that should help us when we launch to come across as, very well uniformed and able to tackle any problem that comes our way.
Thank you, Sean. Let's go with Team 11. Saurabh, you want to talk a little bit about maybe a bird's eye view of what we're doing, and then I'm going to turn over to Marcos, and then we'll go into the specific areas for each of the research projects that we're working on.
Yeah, sounds great. So I'm really happy to say that I've had a great experience so far working with all these people at Larkin, and I'm really glad that we're able to make some impact. And we have got a IND ready to go for BCG vaccination. It's going to be a non-recombinant vaccination in looking at healthcare workers specifically. So we will work to assess the efficacy and safety of BCG vaccination in healthcare workers. And we're going to look at biomarkers in particular. We're going to look at their categories of severity. We're going to assess these people for about 3 months. And we're also going to be doing a follow-up trial application with the pediatric population. And then we're going to do another BCG trial with recombinant vaccination. After that, we've also got a group looking at quercetin, isoquercetin specifically, the beta-D-glucoside version, and we're going to compare this natural protease inhibitor to synthetic protease inhibitors like sequinavir and atazanavir, and we're already making tremendous progress with that. So we also have other studies like Xofluza and ozone, and then people are interested in working on projects like EGCG, which is a green tea derivative of the extract. And all of these products have shown good low EC50s, so that's why we're choosing to work with these products. Then we're also looking to do a review paper on tocilizumab, and we also have another project with plasmapheresis coming out. It's just starting, and there's already a wonderful protocol in place, and we have that from the IRB, so that should get a head start. And we have also, I'm really glad to know that we can purchase the products by ourselves independently, and I'm really thankful to Dr. Michelle for that, because that takes care of so many headaches, and that'll just accelerate everything. And then we also have PIs for many of the projects, so I'm really thankful to all the residents who are willing to take time out of their days, and I know they're really busy with all the types of floors and ICUs they're working on, and they have their monthly rotations. So I'm really glad that so many people are willing to work on this, and I'm just happy to be a part of it. So we also have a few more projects coming up on plasmapheresis. So this is going to be plasma exchange therapy. And we're going to do 2 approaches with it. And one is going to look at the comparison of plasmapheresis with Medrol, specifically in cytokine storm. So at that point, what would be better? Would it be better for plasmapheresis to relieve the cytokines, or would it be better for Medrol to be involved, or should we take a joint approach? And of course, in all of these trials that we have, we'll be doing the standard of care for the control groups and experimental groups. And then we are also going to be looking into further applications, maybe other vaccinations that can be recombined with BCG. So we have a lot of options and a lot of work to do, and it's a really exciting field. Thank you so much.
Thank you, sir. So which are the ones that we need a local resident PI? Like I know, for example, ozone, Dr. Richter is already going to be the PI. He already took the CITI and all. He's ready to go. Dr. Richter, want to say a couple of words about ozone? Maybe 1 minute about ozone?
Yes, sure. Yesterday, finally, we got the supplies. So the Larkin South team nurses are already trained. They are ready to start, of course, under my supervision for a few days. We did a first consultation on Wednesday. Unfortunately, this patient was allergic to heparin. So that's one of the major problems that would probably she's not a good candidate, because we have to use some heparin in the line, in the transfusion line, before we draw the blood. So, but now for Larkin South, we're just waiting for to hear from more consultations, so I can review and check the patients. And from Palm Spring, we set up already a first training for next Wednesday. So we're gonna start training the nurses in Palm Spring. And I think somebody mentioned that they have a few consultations in Palm Spring. I never got a reported which one, because if they're still there, I can start looking at the charts, review the patients, but I don't know which one so far. So
Maria, can you look into that and then get back with Dr. Richter or Catherine? Sanjay, you're working on the actual IND submission to the FDA, right? And one of the things we found out is that there's no current study in the United States with ozone, right?
I think that's correct.
Hello, everyone. This is Sanjay. I'm an ECFMD certified graduate from Nepal, and it's been a pleasure to be part of the team. And so we've just started to work on ozone. As per in United States, there are currently no FDA approved trials, though there are trials that are running in different parts of Europe. So actually we are trying to model those trials to our study. So we've only started and we are working on our IND. We have a group already, around 30 people who are working on it. And so we'll be basically, as Dr. Richter told, we'll be basically focusing on major autohemotherapy. And basically what we are doing is we are trying to come up with a plan, a study design, and we are also trying to come up with an IND. So yeah, that's about it, Dr. Misha. Thank you.
Thank you. Which one are the ones that we're missing a PI on? I thought for photophoresis, right, Sora? We don't have a PI?
Right, we need a PI
And
for...
also Zofluza.
Go ahead, please.
Prathima?
Yeah, Zofluza.
I believe we need a...
What you want to say? Yeah, go ahead and talk about Zofluza. Yeah, and then we'll talk about photophoresis after.
No, we are missing the PI on that too, I think.
On Zofluza?
Yes.
Okay, so we're missing a PI on Zofluza. What by that we mean, so we have most of our volunteers already trained in the CITI, but we need a local licensed, preferably resident or faculty member that could take on the project as local PI, because we need someone that can prescribe. So I don't know if anybody's interested on Zofluza. If you can contact either Prathima or Kinal, any of the residents or chief residents or any of your residents that are currently licensed, we could use the PI for Zofluza, right, Prathima?
Yes.
Dr. Michelle, this is Kanal. So for Zofluza, we do have Dr. Novera, who is working closely with, I believe, with Dr. Marcos. So they are going to identify a PI for the trial. Okay, and so Marcos, are we missing then? Can we go through that right now, Marcos? Like, who are we missing for PI? I don't know if he's still here. Maybe we lost.
Oh, they mentioned the needs and the candidates that we have for each of the trials. For Zofluza, my only concern is that I don't see a trial because every single patient is getting Zofluza. So,
no, but that's the whole point is we're going to randomize it. We have several, I mean, they're working on several protocols right now.
So those are they mentioned what is needed. It's basically a licensed physician that it's going to be supervising the project and reviewing, making sure that the patient qualifies for that particular trial.
Yeah, so for all the chiefs and all the program directors, if you're interested in being part of it, doesn't matter what your specialty is. We just need, I mean, basically, we got a team of 30 people per project that are basically, a lot of them are either medical students or graduates, and they're pretty much everything ready. We just need kind of the person that can, the local physician that will head the project. So we have Zofluza open. We have photophoresis open. What else?
And there's also, so we've split the quercetin project into 3 trials, and we have a PI for the first trial, Tashi. She had expressed interest in it. I'm not sure if she would be able to do all 3. It would be great if she can. And if she is busy, then we possibly need to have another PI for quercetin 2 and 3. And these are specifically going to be projects looking at a open label clinical trial that will compare natural protease inhibitor, basically quercetin, versus a synthetic protease inhibitor, saquinavir, as a prophylactic treatment against COVID. The other trial will do a single-blinded approach, the same concept, but it'll look at efficacy instead of prophylaxis. So we'll actually focus on a inclusion group that has COVID patients already diagnosed either by imaging or by antibodies. And then, so for both of these, we will need to have PIs definitely. And then, as mentioned, we have the plasmapheresis pending, and we also have we will need for plasmapheresis. Tashi is on it also, so if she needs any help or anyone is interested in being a co-PI, we'll be glad to learn from you. And also, we have a trial on green tea extract, EGCG, and basically this trial needs a PI, and we're going to be looking at several flavonoids to compare the efficacy of EGCG. We're going to look at its EC50s. We're going to compare different flavonols. We're going to look at how it interacts with the ACE2 receptor, with helicase, with DNMTs. And we have, I'm so glad that Dr. Michelle has the all the tools that are needed to be able to assess these. And we're going to work with a group called Cardiotropic Labs, and they have everything that's needed to work on these transcriptomic approaches. So that'll give us a really solid study. And I hope someone will be interested to work on that with us.
Hassan, are you interested in any of these things? Hassan Nazir?
Sorry, what was that?
Are you interested in any of these trials that setting up as PI?
Yeah, I mean, we're interested. Like I said, us and the fellows, we're always ready to do something. So just let us know and put us in contact with him. You can give me his email and we'll set it up.
Can you put in your contact information on the chat?
Yes, sir.
Karen, anybody in the PM&R that would like to be a part of this, either faculty or senior residents? Karen Rosen? Or Saeed Rana?
I think, let me jump in. I think we discussed on Monday that we need to get this organized this way. We need to have a pager per project with a rationale, projected patients that need it, because that description is the one that I can use to find people that might cooperate as a PI. Right now, I have some projects in my end, but I'm hearing so many things that too many moving parts. I need to have a list of projects, rationale, 10, 20, whatever studies are, and then we can share that with the residents and faculty, and then they can pick the ones that they believe they can cooperate or participate from.
We have preliminary INDs on each of these projects, and each project has a team of 25 to 30 people, and they're already writing a document in IND format, so I can just share all of them with you.
Yeah. That'd be great, Sora.
That can serve as the rationale.
Talia, you volunteered to one of them, right? Talia?
Yes, I'm sorry, I was muted.
No,
Yeah.
no problem.
I have volunteered for two, the N-acetylcysteine and the tocilizumab project.
Okay, great. And then Humberto, I don't know if you can sign up for something. I mean, we just need, I mean, we got a lot of people working, and I just need the residents to kind of, either the residents or the attendings, senior residents with licenses to be able to sign up for some of these things. I know some of you are on the wards, but the ones that are not, or the ones that are fellows, I mean, you'd be ideal for these things. Or anything else, Sora?
That's all.
Actually, John, any of your residents interested, or maybe you're interested in some of this stuff, John Ciara? We can't hear you.
Oh, there. I don't. I mean, the ones I have are graduating very soon, so I really only have one resident who might be interested, but she's going to be on away rotation, so I don't know, not at the moment, because
Okay.
everyone else isn't really here yet. So.
All right. Let's just keep looking. So anything else, Saurabh?
So we have worked a lot on the IND1 for BCG. So if you like, I can share some aspects of it.
Mm-hmm. Yes.
Okay, sure. So basically, we're going to be doing a single-blinded study. We're going to be using the Tice strain. It's from Merck, and we have a ability to do direct purchasing of this vaccine. And we're going to do an intradermal approach. We're going to do 1 ml drawn in through the syringe in the patients, and it'll be injected in the deltoid region. We're going to be monitoring for any adverse effects, and we're also going to be checking for the efficacy based on the incidence of COVID in these patients. So as I mentioned, we're specifically going to be looking at healthcare workers, and they're only going to be enrolled after negative testing. And we're going to then divide them into 3 cohorts. One will receive a placebo, and one will have a zinc ionophore called elderberry, and that'll be given with zinc, and that'll allow for RNA polymerase inhibition. And then we'll have the cohort that actually receives the BCG vaccine. And we're also going to include a group who has prior BCG vaccination prior to 2019. And then we will also be examining how BCG vaccine will boost host immunity aside from antibody production. We're going to be looking into monocytes and their genetic reprogramming, which is accompanied with upregulation of interleukin-1 and 6. And we can do this by measuring the biomarkers weekly in the patients. Some particular markers which we'll be looking at include interleukin-1, interleukin-6, cystatin C. And cystatin C, actually, it is shown to be a beneficial marker for COVID because it has been shown to be elevated in previous trials that have studied on COVID. So it's basically an inhibitor of cysteine proteases like cathepsin, and it's generally used as a CKD diagnostic marker. So certain factors have been shown to be prevalent in patients who have COVID, such as elevated cystatin C, elevated urea, creatinine, homocysteine, monocyte to leukocyte ratios. And these are all associated with worsening chest progression on CT. So we're going to look at these factors, and we are also interested in examining a few other markers like serum amyloid A. And serum amyloid A is basically an acute phase reactant. It's produced mainly by the liver by induction of interleukin-1 beta, and interleukin-6 and TNF-alpha. And it is also produced at some extrahepatic sites, but it has been reported to be elevated in many viral infections, as well as conditions like pancreatitis and kidney transplant rejection. So it's been shown to be elevated in COVID patients. And the benefits of looking at these biomarkers is not to categorize severity based on biomarker elevation, but that'll still be clinical, of course, based on symptoms. But the benefit is to allow for a general prognostic determination eventually that can help know when certain patients are heading in a certain direction. That way we can better assess what to do about their ventilation, how to change their PEEP, and that will lead to a better approach for us. We're also planning to measure ferritin, and ferritin has been shown to be elevated in severe patients, especially in those with ARDS and even cytokine storm. So ferritin, typically if it's getting above 500-600, then so those are the typical levels seen in COVID patients, and they're going up after that. And I think it's worth testing. So we're going to incorporate ferritin testing as well. We're going to create a baseline for all of the patients. So we're going to have baseline testing as well. And that'll allow us to assess in the long term where these patients are heading. And we're going to do some statistical analyses on them after the study. And we can do the statistical analysis based on age cohorts afterwards. We're not going to divide the patients by age during the study, but afterwards we can, and that'll allow us to see for any associations with age and with COVID severity and with any biomarker particular elevations in different age groups. So BCG is very safe and well studied, and there's a lot of previous human experience with BCG, and they've used it with yellow fever trials. They've used it with other respiratory tract infections. It's also used in oncology for bladder carcinoma. They have a intravesicular administrative form of BCG, and that is beneficial in maintenance treatment for bladder cancer. So we're specifically focusing on intradermal, of course, and I'm just glad that we have made so much progress so fast.
Excellent. Good work, sir.
Thank you, sir.
We're also working on tocilizumab, but we were going to actually do it ourselves, but we talked to the manufacturer, and they're sponsoring a trial. So next week we're going to start some early administration. Marcos, do you want to say two things about that real quick?
Yeah, right now we're in the preliminary phase, and we already have the PI. I've been working with Tanya, which is the CRO company that is facilitating this. And yeah, we have to fine tune some details. And I send the IRB information to her. So transcribe all the information to the local IRB.
So that should start next week. And let me move on to Team 12. Tariq, if you're still here, you want to talk about a little bit what Team 12 is about and your progress at Kendall with the plasma and all that stuff? I don't know if Tariq's still here. Hey, you're muted.
Yeah, hello everyone. Sorry. Yeah, this is Tariq Hakim. I'm one of the residents in Kendall Regional Medical Center, and it's been a pleasure to work with you guys all. All of you have been doing an amazing job, to be honest. So actually, what I did is in the beginning we were speaking about the fact that not other hospitals have the option to have convalescent plasma, or most of them even don't know what is convalescent plasma. So then I was thinking about exploring this pathway and taking it into other hospitals. So I reached out to Dr. Michelle, and thankfully I built a process. Then I went to our hospital, and I was surprised to find that in our hospital there's no one who knows about convalescent plasma, and it wasn't even administered before. So then after that, so I approached the ICU attendings, the ICU team, and I gave them exactly what is convalescent plasma and we should do it and administer it. So after several a conversation about this and teaching point and all of this, we thankfully administered to several patients, and after going through the process. And they were happy to do this. Then after that, they were keeping it, they were contacting me every time, what is the process, how we can order this. And I got contacts from some of even from the hospital, to know exactly how can we do that in other patients. So after this, then I noticed that no one knows about it. So I built a sheet, a process. I can share my screen if you want.
Sure.
Yeah. So I built a process sheet so as to help everyone to know how to administer convalescent plasma. Yeah. So let me just share this. So this the process sheet, like it was actually helpful, like for most of them. I gave it like to all the residents, the ED physicians, the internal medicine, and most of the physicians in the hospital to know exactly how to administer convalescent plasma. It's basically like going through the steps exactly, the eligibility criteria, the pathways needed, the forms, and what exactly like to do if you want to do it like through the Mayo Clinic or through the EIND. And even like in this like it takes you like to several PDF. Like for example, this is our consent form. Even this is like I built like an example of how you can fill the FDA form, and you can just copy paste it and send it for the EIND. Are you guys able to see the sheet?
See your screen.
Yeah. So yeah, and it keeps going like all of this, mentioning exactly what is the process. Then after that, the program director like he approached me and asked me like to speak about convalescent plasma, so that we can educate the residents. So then I built another sheet like about the background and the evidence behind convalescent plasma. This is basically like explaining the introduction behind it and what is the types and why was it introduced, even the historical usage in several other viruses and type of infections, even like in the Ebola outbreak, what happened and what was significant about the convalescent plasma, and the fact that they're considering it as an empirical therapy since there's no any clinical trials, and even the fact that, as Dr. Michel mentioned, that there wasn't clinical trials, but they weren't able to complete it to the end because of the waning of the epidemic, of the outbreak over there. Even like this contains the studies of the convalescent plasma, and then an approach like based on the studies on using it and how to use it, and why using it early, based on several studies, and even like administering several doses can be also something significant with no side effects noticed. So this is also like this sheet contained the process of ordering, which ordering the convalescent plasma, which is the one that I showed you. After that, this is where I based the recommendations behind what should we do like to increase the convalescent plasma in our hospital and gain a good pool. And basically, like when I read about the WHO, they mentioned that the recruitment like of donors living in areas in which an epidemic has broken out can offer the added value of providing specific artificially acquired passive immunity against the local infectious agent. While convalescent plasma supplied from other regions may be less effective due to possible strain variation of the pathogen in question. And actually, like WHO dealt with this type of situation by two things, like the engagement of the community. And this is where the WHO like reached out to West Africa, and they enabled like effective information, education, and engagement of the patients that are recovered from the Ebola disease and the communities in which they live, so as to consider the donation of convalescent plasma for use in the treatment of Ebola virus disease and for use in clinical trials. So basically, the fact that this was actually very inspiring, like to see the fact that WHO dealt with this and it was successful. And then I presented the approach, like what is an example of how we can engage in the community is by what are you guys doing, the approach that you, because it's almost similar by engaging the community and bringing the convalescent plasma. It's almost a similar concept. And even I feel like the one that you all are doing is more refined and a great process, well structured. So basically, I show them like the different teams and what is Larkin Hospital doing, and how we can volunteer in this type of initiative, and the innovations that are building and all of this. So yeah, after that, then I also I told them like the other solution was to create a register database of patients that recover from COVID-19 disease as potential donors. And actually this approach was suggested by Patrick. So he told me like exactly of what is the right process to do this. And I summarized it like to them on how we should do this and reach out to our hospitals. And everyone was thankful, like they liked the idea. And now we're in the process like building an order set and like making the process easy through our Meditech. And hopefully this work, like it's going to work in our hospital, and the process will go smooth. And I hope we can be able to expand this in other hospitals. And even to be honest, I'm thinking about expanding this in my country over there in Sudan. The fact that no one are using it now, and I'm reaching out like to several leaders over there so we can do something like this. But regarding here, I feel like if we reach out and we build a network between every hospital around the state or around the whatever, like just to have like a basis of residents over there in each hospital. Everyone is leading the group of, for example, the convalescent plasma and the COVID-19, and then build like an umbrella between all of us so that we can share knowledge, we can share processes, we can share the convalescent plasma from the pools that you have. We can share new innovations, we can share drugs. So we can actually, because I feel like every hospital is doing something different than the other. And at the end, I'm sure that there is a hospital that is doing the right process. And maybe that Larkin is the one that is doing the right process. So the fact that we keep sharing the information and we keep we share things, the drugs and the plasma and all of this, like between this network, it will be an amazing innovation that we can build an amazing attack against COVID-19. So hopefully, hopefully everything goes smooth, and thank you all for giving me the chance to speak about this, and looking forward.
Excellent. Thank you. Thank you so much. Let me, anybody else have any comments or questions? I don't want to keep it for much longer.
Yeah, hi, Sean. Anyone who's going to be participating and also in the United States and abroad, can you just make sure that you send me an email to let me know that so we can add it to our list of how diverse we are? Thank you.
Excellent. Well, thank you all. I don't want to keep you longer. It's been an hour and a half, and you've been very gracious. I hope everybody has a great weekend. Thank you so much.
Stay safe, everyone.
Thank you.
Bye.